Okay, good afternoon. My name is Michael Gofield. I'm previously faculty of University of Washington and more recently a faculty of University of Toronto. And I'm an anesthesiologist and a pain physician, and I'm currently involved in research related to specifically to pain applications. So I have three bright scholars who presented an outstanding, in my mind, outstanding and groundbreaking research. And we'll start with Dr. Abdul Karim from the University of Maryland, who is a neurosurgeon, and the presented work was about the false thalamotomy. So the first question goes to you. 4 hours in scanner seemed to be quite long, and
yes,
and it's not unusual to have false MR-guided false procedures long. But you also commented in your presentation that one patient could not tolerate it.
Yeah.
So would it be more appropriate to have patients under either deep sedation or general anesthesia?
So that's an excellent question. Actually, I don't think so. I think here at our institution, these are the first patients we're treating for neuropathic pain with focused ultrasound. So there's sort of a learning curve here, and I think they're going to get quicker. With anesthesia or any sort of sedation, we sort of lose the brilliance of focused ultrasound, which is that you can get live feedback from patients as you're creating these lesions in their brain. So we do have patients who are telling us while we're treating them that their pain has gone away or has reduced. So I think that's also, that provides two things. One is that it confirms that the treatment is working at that time, and then it also keeps us confident that we're in the right location. So I do think it's valuable to have them awake for this. And okay. I think we have to work on that timing.
Okay, well, it's basically use feedback of which is probably very important to have. How did it tolerate the frame?
So the frame is actually very well tolerated. It's a stereotactic frame, and the pins are made out of hard plastic. Any patient we've treated here with focused ultrasound, either for tremor, Parkinson's, neuropathic pain, or brain tumors, a lot of them complain of some pin site pain or a slight headache. We've never had anyone had any of those symptoms last more than a week. So they tend to tolerate it really well. And they are counseled on this before the procedure, because some patients may not be able to tolerate or allow something on their head for that long.
Okay, so let's jump to your results. Two patients achieved very significant result. One was actually resolution of pain, and one was a significant up to 50% pain reduction. It's lasted for a long time. And other patients responded with sort of, a dive kind of in a numeric rating scale, and then pain climbed up, even though not on the same same level. How do you explain this?
So actually, it's a very good question. Two things that come to mind is, one is we already have a lot of literature on lesion production in the thalamus from essential tremor. If you see from prior papers from several groups, the lesion has different zones. One is the central necrosis, and then around that necrosis is edema. And it is possible that as that edema starts to resolve, some of that effect of causing that lesion recedes a little. The other issue is that these patients that you select, some of them have continuous pain, and it's excruciating, and nothing resolves it. And then there's others that they have neuropathic pain, but it's episodic, and it has features of allodynia or other symptoms. The patients that have episodic pain tend to do better with a thalamotomy than those with continuous pain, and it's not exactly clear why, but it is a result that's corroborated by previous results from thalamotomy, both with ultrasound and RF ablation from previous groups, and it's a known difference. So that's those are two reasons why patients may respond differently, and also why their effect may be greater and then eventually level out to sort of a 50% reduction as opposed to a 70% reduction.
And the last question at this stage, same to you, Dr. Ahmed. As an anesthesiologist and chronic pain physician, I know that we have a lot of commonalities in the patients that we see. Yes. And unfortunately, as you know, as we know, that not necessarily what the importance, what kind of disease the patient has, but what kind of patient has a disease. Yes. So that basically goes to your selection as our selection. For example, patient with failed back surgery syndrome may have a host of other psychosocial comorbidities. Correct. And in this sense, most interventions fail, including spinal cord stimulation, other than the concept of multidisciplinarity. So you nicely alluded in your presentation that selection is very important. Yeah. What would be your selection? What if you will be your, I would say, your number one on the wish list of these patients for talonotomies?
So we actually treated one of those patients yesterday, a young woman who had a unfortunate incident that caused a radiculopathy, a single one nerve root radiculopathy. She's 30 years old. She's otherwise very engaged, normal 30-year-old young woman. And we treated her and she immediately had relief. That's my ideal patient, but these other patients that are probably we deal with a lot, these failed back patients, are difficult. And I think even when you make selection criteria for trials, there's always that bias in your mind of, who is optimal for this treatment, for sure. But that's why we had these sort of inclusion and exclusion criteria. Those patients with failed back syndrome and continuous pain, and they require multiple, both medical and surgical regimens, tend to be prone to failure in many different interventions, as we know, unfortunately. We did have one failed back syndrome patient, but they did improve with this treatment, which was very, very encouraging. I don't think that this is a treatment that's going to work universally for everyone. And that's sort of the other process of this. Our work is how to select these patients carefully. But we do have prior work from Dr. Jean Menard and others to rely on to make those selections.
Okay, I will make a last comment. And in my wish list, and when I see a patient with a central neuropathic pain, a patient from post-thalamic strokes, a patient with all type of trigeminal neuropathy, not neuralgia, neuropathy. I'm quite okay with neuralgias, but with not neuropathies. Those patients I tend to refer to my colleagues neurosurgeon from thalamus stimulation or some sort of invasive procedures on the brain, including motor cortex stimulation. So would you consider those patients to be a good candidates for talonotomies?
So that's a perfect question. Actually, our next trial is for patients with trigeminal neuralgia, actually. This is neuralgia that's refractory to any other treatment. As you know, we do microvascular decompression when there's a vessel loop to put a sponge there and separate that irritation. But there are patients that'll have continuous pain, similar to having a radiculopathy. It's like a radiculopathy of the head. And we are actually enrolling those patients in a short while. And I would be very excited to see what those results are. So that's an excellent lead-in.
Okay, so good luck. So now we have a perfect segue because surgeons usually cut, rather than connect, and a mental health specialist usually try to connect. So Dr. Padran from Medical University of South Carolina, I believe, counterbalanced your finding by stimulating this sort of similar target. So, I found that study very intriguing and fascinating. So my question to you, Dr. Badran, what will be your a clinical application of this TFAS stimulation?
So, a lot of the work that you've heard during the conference is by a lot of neurosurgeons who, have to attach a stereotax and then do the whole thing. What we develop is, non-invasive, outside of the scanner, more practical treatments for things like depression, pain, and so on. So our study really is kind of the first study in a series of studies to see if we can create an outside of the scanner intervention for pain disorders. We don't really have a good neuromodulatory treatment for pain outside of the MRI. So that was the first step. If we can attach the single element transducer using MRI to guide it, perhaps then we can take folks outside of the MRI using their structural scans, neuronavigate outside of the scanner, and then create an intervention that perhaps you can administer daily in the lab or in the clinic to treat pain. So that's kind of where we see it going. The first question is, can we sonicate the thalamus and see a signal in pain, which we seem to see. Now, we're not ablating, right? So we're using really low intensity. Some of the findings are kind of mixed because the effects seem to be a little delayed. We don't get an immediate anti-nociceptive effect. A lot of the results you could read in the newly published paper we have in brain stimulation on this. But yeah, it's kind of a really interesting idea that I think eventually the effects will be additive. So perhaps we need to increase the dose by delivering multiple days of this treatment, but it's a good first step.
Sure. So what will be your expectations? So I see in your study, your presentation, the effect on pain was quite significant immediately. How long do you think it will last, either after the single session or a series of interventions?
I'm not sure. We base a lot of the work we do on prior experience with neuromodulatory techniques. Ultrasound is really its own enigma, right? So with things like TMS, you can, which is transcranial magnetic stimulation, we can deliver magnetic pulses to a part of the brain and really not get any major profound effects that last more than 30 minutes to an hour in one session. But it's when you deliver them for 4 to 6 weeks, do you see a huge effect that persists. So with this ultrasound, we see it over a couple hours. I think that eventually we can have a durable long-term effect, perhaps on the level of weeks to months, but we're still not even in the optimized zone yet. We still need to optimize the intensity, the treatment target, and then the amount of stimuli we need to deliver over a certain amount of days.
So speaking of treatment targets, so this old debates between like I call them debates, pain versus pleasure, right? So cutting versus stimulating. Would you consider, or have you considered any other targets for this low-focused ultrasound brain stimulation? Like, for example, I can just throw one of the alpha amygdala. So being a very useful kind of or intriguing zone for any type of either ablative procedure or stimulating.
Yeah, so we're talking now about amygdala. We're talking about insula. We're talking about ACC, DLPFC, and then directly somatosensory, which would be kind of our last ditch approach. We went for thalamus first, only because it's quite a broad. It's like casting a broad net, right? We're catching a kind of deep node. But there are all these other pathways of pain. We wanted to get the signal first. But if I was to bet, we'll probably be going insula, ACC, and or DLPFC next.
Yeah, so you go probably now on a switchboard rather than go to terminals.
Yeah,
it's very, very wise and very, very interesting approach. I may come back to you, but now I don't want to leave Stephen Lee unattended. So Stephen Lee is a researcher from Columbia University, and now we're departing from brain or central nervous system to peripheral. So in my experience and my work in the University of Washington with Pierre Murat, we developed this scanner and our fast applicator and use it on mice model or rats model. And there was a plenty of conversation of why should it work at all? So what is your so-called, mechanism of action hypothesis? So is it a thermal or a low temperature or displacement or both or neither?
Yeah, that's a great question. I think the general consensus here is that it's more mechanical. We've done sort of ex vivo and safety studies to characterize the temperature we get. And the fact we are in this study using single pulses at just very, very low duty cycles in terms of just minutes waiting in between these single pulses, we don't feel like there's any temperature accumulation in this. And furthermore, we've done some preliminary simulations because can't really do much with a healthy human subject. So I've looked at just a simplistic simulation, increasing displacement of the nerve in response to the same stimuli. And it seems that there is a bit of difference in terms of how the nerve bundle responds to different varying levels of displacement. So I believe that it's more of a mechanical action that we're inducing on the nerve during transmission of these pain signals to the brain.
Excellent. I received a question to Stephen Lee from audience. So did you do median SEP after treatment to check sensory threshold and or SEP signal changes?
Right. So a colleague of mine, Hermes Kamimura, did do some SSEP measurements to our focused ultrasound pulses, and he did see that there was some decline in the SSEPs over time. Now, with this, that was just from electrically evoked potentials, and here in this study we're using heat evoked, and so we haven't looked at SSEPs, but it is possible, and that is something that we are considering to do in the future.
It actually was almost the same question I wanted to ask you, because someone who experimented quite a lot with QST, you don't know what to take out of the QST. It's fascinating, but what that means, it's still psychophysical, not necessarily what subject's brain perceives. So I personally think SSCP would be a great idea to confirm or deny sort of this signal changes. So where are you going after that? So that's a great start with peripheral nerve. So what's the next step?
Right. So in the study, we looked at thermal, which is a nociceptive input, where the main goal is to go to neuropathic pain. So the next step that we're going to do is go into the clinic, and we need a repeatable model of neuropathic pain. So we are going to work with a neurosurgeon here at Columbia to look at sural nerve biopsies, so patients that have a very repeatable and robust response to just a mechanical poke onto the nerve, and they have a repeatable pain response to this. So we want to see if we can turn down their pain or see what happens with the parameters that we set forth here. In addition, in the study, we used single pulses, and my hypothesis is that if we increase the pulses, or like the other attendees here have been saying, just increase the dosage or amount of dosage, we might be able to see much greater effects. Of course, we have to do some preliminary safety and histology studies before we go to the clinic, but that's the next step, and hopefully we'll see something.
Thank you. I will keep asking you all, for another hour or two, but unfortunately we need to close our session. It was great to see you. It was my honor to participate in this discussion, and I'm looking forward to read your studies, and probably I hope we can communicate on a personal level and merge our efforts. And thank you for Foundation for inviting me and inviting all you guys to present your excellent research. Thank you very much. Have a good day.